Well, thank you for your patience in allowing me to install the various softwares in order to share it not only here amongst all of us, but to those people who are joining us by Zoom. So again, I'm Joaquin Cigarroa, and I have the privilege of directing the Knight Cardiovascular Institute in the Division of Cardiovascular Medicine, and have the distinct privilege of representing OHSU and our team in all of the collaborative work we're trying to do to collectively improve cardiovascular care in both of our health systems. So cardiogenic shock is a work in progress. In 1973, the overall mortality in a series that Stephen Scheidt published was 83%, and it's been consistently approximately 50% throughout the course of many decades with the reporting of clinical trials. And I would say in 1997, with the publication of the SHOCK trial, for the first time, it was demonstrated that revascularization, primarily by percutaneous coronary intervention, improved survival in patients with acute myocardial infarction complicated by cardiogenic shock. And there are several important distinctions that one should consider. The first is that revascularization in STEMI complicated by cardiogenic shock can show improvement in survival up to 36 hours after the index event. So do not confuse the 0 to 12 or 12 to 24-hour period for STEMI revascularization as being a contraindication to coronary revascularization in the patient with cardiogenic shock. That goes up through at least 36 hours. Now, we've been stuck at this number of a mortality of 1 in 2. And I would say that in the period beginning in 2016 and extending to the present day, there have been multiple publications about improved survival in health systems caring for patients with cardiogenic shock from a spoke and hub system. And the first to report this was the NCSI group out of the United States that demonstrated a marked improvement when they took patients with acute myocardial infarction complicated by cardiogenic shock and minimized variation and chose parameters that allowed them to identify patients that would benefit from revascularization, invasive hemodynamic monitoring, and where appropriate, mechanical circulatory support in addition to vasoactive agents. And this really has been a profound inflection point in how all of us are beginning to address and assess and organize around systems of care to treat the syndrome of cardiogenic shock. And that's what I'm going to focus on this morning. Now, cardiogenic shock is started by an insult. And for the purposes of today, we will focus on acute myocardial infarction complicated by hypoperfusion and the cascade of inflammation, ischemia, vasoconstriction, and in-organ dysfunction. Now, the first thing is, how do you recognize the patient with cardiogenic shock? And that sounds like a simple question that's easy to answer, and yet it is incredibly challenging. And the reason is that historically, we have utilized a systolic blood pressure of less than 90, an index of less than 2.2, a cardiac power output of less than 0.6 watts, and evidence of in-organ hypoperfusion by biochemical markers such as lactate. Now, the challenge is that blood pressure alone is relatively insensitive. And unless you have an invasive line, as of yet, my stethoscope in hand cannot tell me what somebody's cardiac index is unless they already have evidence of profound hypoperfusion with cold extremities. And so historically, we've utilized the systolic blood pressure and cool, cold, clammy. But remember, up to a quarter of patients with a pressure of 90 may actually have hemodynamic evidence when you put a PA line in of a wedge greater than 15 and or a cardiac index of less than 2.2. So you have this reduction in output, and it leads to multi-organ dysfunction. And remember, once the liver and the kidney goes, so goes your patient. It's very hard to pull back from cardiogenic shock complicated by acute kidney injury and acute liver injury. And so the fundamental question is, can we intervene with therapies prior to end organ dysfunction that might change the subsequent cascade of events? Or is the waterfall always going to hit the lowest point and end in death and cardiogenic shock? And that is the conundrum. The second is, what is the risk of the therapies that we bring to bear? And remember that vasoactive agents such as norepinephrine and dopamine, we've always thought that if you maintain a MAP of greater than 65, that's going to be associated with improved outcomes. But just think about the cost to the organs of artificially, with vasoactive agents, vasoconstricting and not necessarily improving outcome. And you think about mesenteric ischemia, you think about increased filling pressures, you think about the impact of the kidney between the afferent and efferent arterioles. And so, although it makes sense to maintain that pressure, and that's how FDA approved all these agents, there's no clinical data that doing so actually improves outcome, as opposed to making all of us in the ICU feel better. And so, where do we intervene? On hypoxemia, on microvascular dysfunction, on pulmonary edema, on how to counteract inflammation, and then the whole issue of the adrenergic system. So if we take a look at these two tables that were published in JAHA by Osman and colleagues in 2021, what you see on the left is the number of patients per 100,000 hospitalizations going back from 2004 to as recently as 2018. And what you see is that there's an increase in the number of patients identified with cardiogenic shock. And so this is based on a national inpatient data sample. So the diagnosis is being made overall more frequently. And in the red, you see the non-AMI cardiogenic shock. And in the yellow, you see the patients with acute coronary syndromes complicated by cardiogenic shock. And so today we have lots of patients with cardiomyopathies who are presenting with acute on chronic heart failure, cardiogenic shock. We talked about yesterday morning structural heart and the number of extreme risk patients with either aortic stenosis or mitral regurgitation or tricuspid regurgitation or a combination of all of them. And these are walking patients with cardiogenic shock that when you do right heart catheterizations, you see indices of 1.6 in patients that for us is referred for right heart catheterization as part of the evaluation. It's really remarkable at the adaptation. Now, what you see on the right is the different portions of the United States, and you see the variability anywhere from 45 to 55% mortality back in the early 2000s. And today, now overall rates of approximately 40%. And the question is that 40% and therefore the reduction of 10 to 15% in mortality because we're capturing more patients, or does it reflect improvement in the care, primarily the advent of broader coronary revascularization and lessons learned on how to revascularize patients with shock, culprit followed by stage in about 1 in 5, and or the use of mechanical circulatory support, or is it simply a coding issue, right? We don't know. But this is what is occurring in the United States. And today, tracking in the the 4 identified regions, you see overall a mortality rate of about 40% in an all-comer group of patients classified with cardiogenic shock. Now, what is clear is that there is profound variation in care. And when we take a look at this, you can see that based on gender and ethnicity, based on where you show up from a low volume versus a high volume, there are differences in clinical outcomes. Even within hospitals, depending upon race and gender, there are differences. There are differences whether or not you have the ability to implant percutaneous and or permanent left ventricular assist devices. And then depending on the time of day or night, or whether you present on holiday, weekend, or work day, there are differences. And whether you present on a weekend from weekday, there are differences. Now, is that fair to the patients that we care for, that depending upon where you show up and time, that you get different treatments and different outcomes? And so the reason we're convened today is to try and improve the reliability of the system of care. And I would say that it becomes incredibly important to develop a spoke and hub approach with consistency of how we diagnose patients with cardiogenic shock, how we utilize hemodynamic monitoring, how we employ revascularization, how we utilize vasoactive agents, and how we utilize mechanical circulatory support. And I will tell you, overlaying all of that is do not discount the ability of a clinician and or a group of clinicians to identify patients in which care that we provide is going to be futile or have an opportunity to improve the survival of care. And I think you're going to see that as I go through the systems of care versus randomized clinical trials. And so clinical acumen, in addition to reducing variability of care, I think are two of the secret spices to have the right sauce to appropriately have a cardiogenic shock program. Now, we have to make sure that all of us are speaking the same language so that when we get together and we speak a phone to describe a patient, it's not okay for me to contact Dr. Czar and say, I think the patient looks okay. What does okay look like to me? It's like in my family, I'm tall. In Dr. Czar's family, I'm not tall, but I still think I look okay. Shock is no different. And so one of the nice things that our societies have been doing is to create a nomenclature so that we all are describing the same patient. And that is hard to do, but critically important to do. And so just like heart failure, we now have classifications in shock that go from A to E. When I get called about E in extremis, guess what happens to almost every patient? No time to die because most of them die. It's very different when you identify the patient at risk, beginning, and or classic. And very important to understand if somebody is beginning, whether they are working towards an improvement or towards deterioration. So this is the time that recognizing the patient, understanding the hemodynamics, the etiology of shock, and whether or not there's a reversible condition becomes really important to understand whether or not an acute event provides the opportunity for what we refer to as recovery pathways. Is that patient hemodynamically stable but at risk? Are they hemodynamically unstable and are now as a stage B? Are they now classic shock with evidence of hypoperfusion, which is stage C? Are they not responding to therapies and deteriorating and progressing to stage D? Or are they extreme with refractory shock and now at stage E? So again, the group that we will focus on today is the acute coronary syndrome patient. And that is an important group to focus on. And why is that? That's because Judy Hockman demonstrated that in the 90s, that coronary revascularization with appropriate ICU level of care, and at the time, mechanical circulatory support utilizing an intra-aortic balloon pump, was associated with improved outcomes. Everything else to date has not been associated with improved outcomes. So then you have to think about what is the destination for that patient. Are they a candidate for renal replacement therapy, ventricular assist device, transplant? And that's why today we will focus on the acute coronary syndrome patient. Now, is the shock classification scheme of prognostic value? And what you can see here from the multiple investigators is that patients in the dark blue who are stage A across all of these different registries have the lowest mortality. And conversely, independent of which of these registry data sets you look at, if you are E, you have mortality rates that go from as low as 50% to as high as 85%. So setting the stage of what patient desires are and family values are, and the limitations of what we are able to accomplish in that group is important in the stewardship of the ethics and resource utilization for your patients. And so we think the sweet spot is in that stage A, B, C, and occasionally D. And then how do we identify how sweet is too sweet or just the right amount? And that's where we combine shock severity, the type of shock and what the cause is, and then what the risk modifiers are. If you're 85 and your lactate is 8, and you have kidney failure, and your infarct was 40 hours ago, there's nothing modifiable there. Either the patient will survive on their own or have a complication of the therapies that we administer, but they're going to do what they're doing. And so I think that's what makes this so complex. And that's why it's so important to juxtapose our clinical judgment, understanding the disease state, and then understanding what our tools of revascularization, vasoactive support, and mechanical circulatory support can and cannot do. Now, we talked a little bit about why hemodynamics are important. And there are people who confuse the use of hemodynamics for acute on chronic heart failure decompensation, the ESCAPE trial, which showed no benefit, to AMI complicated by cardiogenic shock. And I will submit to you that we should not have that level of confusion, number one. Number two is that how can you phenotype shock and understand whether it's left ventricular, right ventricular, biventricular, and how can you determine whether or not the therapy that you are administering is having the intended impact by simply blood pressure? And I don't think you can. Will there ever be a randomized clinical trial that demonstrates that the use of PA, insertion, and hemodynamic guided therapy is associated with improved survival? Now, there is a trial underway that Naveen Kapoor is leading. But you actually have to believe that there's equipoise. And how do you guide how to ramp your Impella, or whether the balloon pump is enough, or whether you're dialing in your PA catheter vasoactive agents appropriately? So if you don't believe there's equipoise in being able to manage the patient minute to minute, hour to hour, then you can't participate in the trial. So this to me is a malapplication of the use of randomized clinical trials to show what is clinical common sense. So what we have here are two slides. On the left is the use of a PA catheter and the associated mortality. None has the lowest survival rate. The use of a PA catheter, but not incorporating all of the appropriate indices, has an intermediate survival. And the best survival is in patients in which the clinicians utilize a PA line and utilize all of the hemodynamic indices in order to guide therapy. And so this really is the best data that PA line use is associated with improved survival. Now, despite that, the range of utilization of PA catheters is anywhere from 8 to 73%. And I will submit to you, how can you determine whether you're going to use mechanical circulatory support without a PA line? Are you still going to use your stethoscope and your hand? All I can tell you is I don't hear as well as I did when I used a stethoscope at 35 years of age to hear whether they're Rawls or not. And because so many patients have pre-existent comorbid cardiovascular disease and revved up lymphatics, my ability to tell you what the pulmonary capillary wedge is by listening to a patient is very poor. And so if you think about from a system of care, should we leave it to the clinician to determine when we use a PA line, or should we all agree that we should classify patients and appropriately, by guidelines, make sure that whether I'm on call or you're on call, that we all come to agreement what type of patient should have a PA line, what are the numbers that we should be following, and what are the therapies that we should be employing based on that. And I think that's the best approach. And if we did that, you wouldn't see this degree of variability, and we wouldn't miss as many patients. And time is critical in these patients, because the longer the time is from the acute insult, the longer the duration of inflammation, the more the number of organs that develop dysfunction, the higher the mortality. And if in fact you can't tell if your hemodynamics are improvement and your lactate is clearing, then you're flying in a storm with no instruments. And the last I've known is a pilot flying an airplane in fog with lightning and surrounding mountains that can't read instruments is not a pilot you want to be with. So do you want to be with a cardiologist who's not rated to fly with instrument alone? And the answer is, I don't think so. So here are all of the clinical trials that have used vasoactive agents in patients with shock of various etiologies. The largest one was 1,300 patients. The smallest one was 57 patients. And no difference in mortality in any of them. Some are underpowered, some are powered appropriately. But the question really is, are you ever going to be able to select the right patient, the degree of support, and demonstrate an improvement in survival? And the answer is no. Are you ever going to have a patient with shock and state that you're not going to use a vasoactive agent to support their mean arterial pressure? And you can argue whether the MAP should be 55, 60, 65. Historically, it's been 65. And I myself prefer 60 because of the negative effects on mesenteric ischemia and other things. How much is enough? But all of these trials are negative. That's not a reason to not use a vasoactive agent. Every randomized clinical trial utilizing mechanical circulatory support have been negative as well. And, the question is it because we have too many cardiac arrest patients with refractory VF that are going on to ECMO? Is it because we are enrolling the patients after the crash has happened and the car is totaled and the insurance company says, not much you can do? Is it because of differences in the population? Is it because Faraz tells me, hey, Joaquin, I know who can survive and I know who is futile. And so I'm not going to randomize a patient that I know can survive. How many years did it take to enroll patients for the shock trial? Take a look at all of the US-led randomized clinical trials in which our bias, because we actually don't think there's equipoise, limits the ability to determine that signal. Is it because we have identified all the patients that we believe in and only enroll the patients that we don't think will benefit? So we might as well enroll them in a trial so that at least we can better understand it. And is it because we're targeting the wrong patients with cardiogenic shock? Maybe there are too many A, maybe there are too many E. And if you're in the A, the vast majority are going to survive. If you're in the E, the vast majority are going to die independent of what you do. So these are all of the challenges. And just last month in the New England Journal of Medicine, there was yet another negative trial with ECMO. So is that a reason to say we'll never use a vasoactive agent, we'll never use a PA line, and we'll never use anything other than coronary revascularization with a balloon pump? And the answer is no. And I'll tell you why. So when we look at patients with cardiogenic shock, many of us have evolved to a period where you want to use the least amount of vasoactive support and the earliest revascularization and least risky mechanical circulatory support in an effort to support your patient through this acute insult and avoid all of the systemic inflammation and multi-organ failure. So for the sake of this morning, we're going to focus really only on two, VA ECMO and Impella. And it becomes really important to understand that maintaining systemic arterial perfusion pressure and output with VA ECMO is outstanding. However, VA ECMO does not rest the heart and does not necessarily improve coronary perfusion. And the reason for that is because it has a marked increase in afterload. So if you think about the patient with an acute myocardial infarction, an occluded LAD, reperfused with no reflow, myocardial edema, and an already elevated left ventricular end-diastolic pressure, and now you increase afterload, how are you going to give that myocardium a fundamental chance to recover? Very different than acute fulminant myocarditis. Two very different pathways. And so I think that when we think about VA ECMO in the acute setting, that is secondary to an LAD infarct, you really have to think about what other things do we need to do in a chance to improve tissue perfusion of the myocardium. On the other hand, when you take a look at the Impella, it both improves forward output while reducing afterload and has an opportunity by the two of those to more theoretically rapidly recover LV function and myocardial perfusion when the insult is an AMI. Now, both of these therapies carry with them very high complication rates. Bleeding anywhere from 1 in 4 to 1 in 3. Vascular complication rates with ischemic legs in anywhere between 5 to 15%. Hemolysis, stroke. So they are challenging and they're not perfect devices, but they are really good devices. And we just have to figure out when and how long in which patient. And I would say that there are times where they should be combined, because in the acute MI, you have to think about how to vent. And there are many different ways that we can vent. But I would say typically in that patient population, we really have to say, is it reasonable to not vent, and start from the position of we should vent. Now, the only way we are able to bring together the collective expertise that is required to identify the right patient, the right agents, the right mechanical ventilatory strategy, the right reperfusion strategy, the right support for the kidneys, the liver, the gut, is by having a team-based approach. And so we must have a team-based approach because of the complexity of the care, the different perspectives. We must actively develop and design shock teams. And a shock team just doesn't mean bringing together a cardiologist and an intensivist and a heart surgeon. You have to take the time to become a content expert in the natural history of that disease and on the advantages of a therapy, as well as the limitations of the therapy. If all you do is focus on the theoretical advantage of a therapy, and you don't go back to those 3 lines of etiology, patient comorbidities, and therapies, and bring those together, you can never appropriately have an effective shock team. And I think that's a really important thing, which now means that if you are a cardiologist or a pulmonary critical care, you actually have to invest yourself and become a content expert in shock and in the etiology of shock so that you have a meaningful chance of impacting it. And if you do that, then you can have a team-based approach that you can populate in a spoke and hub network. If all you do is bring together people of different specialties, but they don't become a functional team, then it's an organization chart and an inability to have effective implementation. And I cannot stress upon you how important that point is. So if you go back, and this is experience that we have learned from one of the 3 US health systems that has really developed an outstanding shock system of care. They went back and looked in 2016, and they looked at what was occurring that was potentially limiting the outcomes of patient care and outcomes, and challenging effective communication and organization amongst really good clinicians. Fractured care, under recognition, too late recognition, not having prioritized access to care, and not utilizing the therapies such as PA catheters to effectively diagnose, having completely different philosophies of care about when MCS was important, when revascularization was important, and how to do revascularization. And so all of that led to random outcomes and random systems and no improvement in outcomes. And so this is their timeline. They assembled their team in 2016. They began intensive education concurrently with that of house staff, emergency room, nursing, intensivists, critical care, cath lab staff, and the entire general cardiology group. They then began to agree when they would activate, and based on every activation, just like we do with every STEMI case, debrief what went well. Where was there disagreement? What were the complications, and what were the clinical outcomes? They reviewed how they communicated. I mean, let me tell you, if I'm in a hospital in the community and I call the big quaternary center and there are 18,000 people all asking me questions about what I've done, I'm not going to call that place back. If there is a group with one spokesperson asking how we can help and asking just enough but not too much and making that person feel good about their care that they're delivering it, and work overtime, not at the time of that call, with their team, that's a much better outcome. And so they then developed this health system, and they've been working together as a group and have now included almost 1,500 patients. And they do root cause analyses about what causes fractured care, why the diagnosis was missed and delayed, what challenged access to care, getting into a cath lab or getting into the right hospital, and then how did the care vary depending upon which providers were working together. If you think about the multiple number of people who come together and the number of variations of people caring for that patient over the course of a year, you really have to work on this consistency. And so that allowed them to continue to iterate their guidelines and mutual expectations of each other and the accountability to each other. There's not blame here. They're processes to improve how we engage each other. And so on the left is their algorithm. On the right, you can see the differences in outcome. The red line, acute decompensated heart failure, the blue, AMI. And what they were able to show is at their quaternary hospital that the clinical outcomes improved. I can't tell you if this is because they use PA lines, because they use Impella, because they selectively use ECMO, and they use revascularization. But I can tell you that the system of care has done a far better job of identifying patients who can benefit from therapy, and that their system of care has identified more patients who are benefiting with improved outcomes. Do I care as to whether the Impella is the reason or whether the PA line? I really don't care. What I care is they have the secret sauce that we've learned about identifying patients where their system of care can improve survival. And I think it's a combination of all of this. Utah has demonstrated, NCSI has demonstrated that, and in our own center, one of our heart failure specialists, one of our cardiothoracic surgeons, and Faraz has led our effort to develop alignment about how we approach our patients with cardiogenic shock. And that leads to the standardized and comprehensive cardiogenic shock care, identification in the spoke, what the hub is, how you involve first responders, and then how do you go from left to right in developing this system of care that involves all first responders, spoke hospitals, hub hospitals, cardiologists, critical care, intensivists, cardiothoracic surgery. And when you do this, you can improve the reliability of the system, and that improved reliability of the system improves outcomes and improves resource utilization. And this is Inova, University of Iowa, and the third center. And you can see moving in all three cases, improve survival, reduce mortality, and reduce mortality compared to the historical controls prior to developing agreements on how we diagnose, how we use invasive, how we use revascularization, how we use MCS. Three geographically separate entities in the United States. Very different patient populations, but they all demonstrated this improvement. And so we now strongly believe that it is a system of care and the principles on how we treat cardiogenic shock, secondary to acute reversible events, that can improve clinical outcomes. And you can see here in the shock team versus no shock team, the characteristics of acute myocardial infarction, the number of admissions, lactates, wedge. And you can see here, interestingly, that if you have a shock team, that you have an 11% greater use of hemodynamics. Interestingly, more selective and appropriate use of mechanical circulatory support. And in terms of the overall MCS, but you can also see here that they're phenotyping the type of shock and selecting the type of device based on the hemodynamics and the cause, and not just using the same device for every single patient. And that has resulted in a reduction in their ICU mortality. You can quibble about what numbers, which device, but you got to standardize it and you got to implement it. And in order to do so, you've got to agree on how to diagnose it. They have taken all that information. They had the original algorithm, and then they've increased the specificity about how to activate, how to coordinate, and how to manage at every phase of care. And remember, it doesn't just stop about recognizing it, fixing the vessel, and putting the device in. The management around the patient at each phase is critical to avoiding complications, recognizing complications, treating complications in an effort to improve the survival. So there should be a structured approach. You should assess the hemodynamics. You should know the coronary anatomy. You've got to understand the peripheral anatomy. You can't ignore the right ventricle, and you don't want to crash onto support. By the time you're crashing onto support, you're going to be 80% mortality. So you got to get upstream. And then you've got to know if what you're doing is actually improving the patient. So I'm going to finish with this most recent trial that was just published. And we held a journal club on it in late August. And this is the NEJM ECMO in cardiogenic shock that Dr. Thiel has shepherded. And it's a remarkable clinical trial. And its goal was very simple: to examine whether treatment with ECLS, in addition to revascularization and medical therapy, is beneficial to all that therapy without ECLS in patients with cardiogenic shock with respect to 1-month mortality. Now, they truly believed there was equipoise, so they enrolled every patient who met the eligibility criteria. So think about that for a moment. Who met eligibility criteria. Now, if Dr. Domris is going to see a patient with acute myocardial infarction complicated by shock, he's going to look at those 3 arrows and come together and say, feudal care, I don't know, what are the family wishes, or I really think this person is going to benefit. And that's an important context to assess the impact of this clinical trial. So patients from 18 to 80, acute MI, and they must have planned revascularization of a culprit lesion. They must have evidence of hypotension and or the use of catecholamines to maintain this pressure of 90, evidence of organ hypoperfusion by altered mental status, cold, clammy skin, decreased urine output, a lactate of greater than 3 millimeters, and informed consent. Revascularization strategy was left to the individual site, and as is most common in acute cardiogenic shock, it's primarily PCI. The willingness of our cardiothoracic surgical colleagues to take moribund patients and try and utilize cardiac surgery those patients is quite challenging. Drug-coated stents were recommended, and non-culprit lesions were not done at the same moment, but were staged. When you look at culprit shock, about 1 in 5 patients had staged revascularization. If in fact the interventionalist said, I can't do it, we look to our wonderful surgical colleagues and say, it's 2 in the morning, I don't think I can do this, can you kindly help us? And the smile is, we're happy to help. And they were transferred to the ICU post. MAP goals of greater than 65, anticoagulation, the love-hate relationship with heparin, and higher goals for your output if there was evidence of low output or impaired pulsatility. Everybody had A lines, and everybody had regular limb assessment because of the high probability of ischemia in the limb where you had your cannula. Now, only a minority of patients were venting, and a lot of people wonder, I think there was less than 1 in 6 who were vented, but they were very specific. They said venting if there was no pulsatility on the arterial waveform, no evidence of aortic valve opening by echo, impaired VTI by echo, or the fact that the LV was beginning to descend. And then they utilized Impella or balloon pump or other. And I will tell you, of the minority of people who were vented, the majority were vented by intra-aortic balloon pump. And this is an interesting slide, just as an illustrative evidence of what happens to an elevated pulmonary capillary wedge pressure in shock. If you do ECMO alone, it often does not decrease. And if you do ECMO and venting, then you're able to reduce that wedge. And that's why it's so important that you always assess and start from the question, I need to vent unless we see the following. They had very specific weaning protocols, daily assessment as to when we might consider it, and then how to go about ECMO weaning. So again, very consistent management options, independent of who the clinician was. No surprise, both patients got ICU therapy with agreements upon when we would introduce renal replacement therapy, which is common, and how we approach mechanical ventilation and assisted ventilation. This slide on the procedural characteristics just goes to show you that the vast majority of patients were revascularized by PCI, over 95%. So this was revascularization of AMI complicated by shock and MCS along with standard of care for ICU. And what you can see here on the left are the Kaplan-Meier curves of mortality, randomized per protocol or as treatment. And it's very interesting. 48% of people, or 1 and 2, died in both arms. And so when you do this in all comers with AMI, the trial did not demonstrate a difference in survival. And so the question is how do you reconcile this with those 3 health systems that have demonstrated improved outcomes? So in this trial, among patients with acute AMI, ECMO failed to improve 30-day survival, and no surprise, was associated with safety concerns due to an increased risk of bleeding and vascular complications. And despite this lack of evidence, especially in the United States in the COVID and now post-COVID, there's a tremendous increase in the utilization of ECLS, inclusive of patients with refractory VF arrest. And so this study is an eye-opening study that demonstrates to me that we have to be selective about the right AMI patient, the right revascularization strategy, and selective utilization of MCS, and goes back to that sky shock and those 3 vectors to identify the right patient for ECLS. So in conclusion, cardiogenic shock remains a clinical syndrome with multiple etiologies complicated by high mortality and morbidity. We must provide and develop systems of care for the treatment of acute myocardial infarction complicated by shock in order to reduce the mortality in the right patient relative to historical controls. It is not right of us to state that cardiogenic shock is a fetal state. It is not a fetal state. So I would not use that NEJM article to say never. We've got to do better at identifying the right patient. You can't identify the right patient if you don't phenotype them and use your clinical judgment. It is known already since the 1990s that revascularization in AMI patients up to 36 hours after the index infarct will improve survival. And Judy and her colleagues demonstrated that. We're very good with mechanical circular support in improving hemodynamics, but our therapies carry with them substantial risks and in RCTs have never improved survivals. But in systems of care, they're associated with improved survivals. And by the use of echo and hemodynamics to shock profile our patients, we can improve clinical outcomes and choose the right therapy for the right patient at the right time. And I believe by doing that, we can in fact improve outcomes. So clinicians working in systems of care can in fact effectively treat the right AMI patient complicated by the right shock treatment algorithm, the right revascularization, the right mechanical circular support, and reduce overall mortality to under 40%. And that is a remarkable achievement. It is not an easy achievement, but it is a remarkable achievement. And the challenge I provided our group was to get together our principles and philosophy of care and to organize ourselves and then work diligently to implement these systems and to monitor all of these very important points in order to say, what is the health of our system of care? If the health of the system of care is good, then we as clinicians can do an outstanding job caring for patients with shock. And that is my challenge to BDMS. Spoke hub philosophy. Come to an agreement about how to diagnose it, who to treat, and then track your data. And you'll be able to tell, relative to historical controls, whether you're improving the care that you are providing to all of the wonderful patients that BDMS is able to care for. Thank you so much.
Thank you very much, Prof.
I hear Wanapa.
Yeah, hi, Prof. Excellent lecture. Even though I'm not cardiologist, still can understand something. Any question?
Thank you very much. This is a very, very excellent lecture. Not just talking about cardiac shock, but to, I said, shed out the light from the tunnel. In Thailand, we don't have any national shock center. We try very hard, we struggle, but this is one of the best lecture that I have ever heard on the how to set up the team-based approach to the cardiac shock. And I might say that BMS is part of the journey to excellence, and we try to help the country to set up these things, but we just don't just waste money, the machine on the device, but we have to do everything as you mentioned. I promise that I will re-echo your presentation through all channels that we have to ask people, to ask our interventional colleagues to listen to this the lecture carefully and slowly, slide by slide, and we will sit up and discuss together again of the way that we are going to go. And thank you very much that you show how to be on that stage. Open the light at the end of the tunnel. This is the first time that ever I said in Thailand that we are talking. In the past, we have Dr. Thiel come here to talk on the MCS, on the ECMO, on the Impella. But it is something that we are not reachable. But this time should be the first time that we are setting up our team. And we will consider thoroughly to what you present, and we will do listen and share again and again and again through all the channels that we have. Thank you very much.
Thank you so much, Dr. Damaras. And I think this is, in cardiology, we are enamored with randomized clinical trials. And for us, is going to laugh when I say this, I don't think this is a space for randomized clinical trials. I think this is a space for registry data and outcomes, because we'll never show a difference with a randomized clinical trial. It just, there's too much heterogeneity. So I think that it's very important to understand history. And if you look at those two slides on RCT for vasoactive agents and the the slide for MCS, there's 100% concordance. So how are we ever going to design the clinical trial for the right patient and address equipoise versus what we've demonstrated as clinicians to be able to select out? And that's the challenge. So I think the registry data that BDMS has invested in and has developed for the KPIs and to identify processes to focus on quality improvement is a model that will become very important to apply in this journey of developing a system of care around acute cardiogenic shock.
Thank you very much, Dr. Scoop, for your great information and lecture. I think in the past we had familiar with the classification of ACS with shock, that is class 4. But now we have ABCDE of the shock. I would like to ask you, I think the combination of MCS by using IABP plus ECMO, because in Thailand, Impella is not available. Did you have experience of combination MCS of the intravenous pump and ECMO?
Yeah, so I think that as you point out, there is this in the United States in particular, and Dr. Zara was talking about this yesterday, the explosion of utilization of Impella has been unlike anything that we've seen. But it's not the only tool, and that's where understanding the cardiac power and what your systemic vascular resistance is. Because there are patients who benefit from IABP, and those are the individuals primarily who are in that BC and who have an elevated SVR to begin. If you have vasodilatory shock in the setting of AMI complicated by cardiogenic shock, an IABP is not going to do anything for you. But it is a very effective tool to vent. And there's nothing that frightens me more from a complication perspective than ECPella, right? Both groins have large cannula, and the vascular complication rates are quite high. And so I start from the perspective that you mentioned, and that is we need to provide support in this patient with shock. This particular one has both LV and RV and or issues with oxygenation. We're going to use ECMO. Very rapidly go through your checklist. And I much prefer to use an IABP because it has a vastly lower complication rate from a vascular perspective and from a hemolysis perspective. And usually it's enough to vent. So I think your point is very well taken.
Thank you very much.
Any other questions from any of the folks on Zoom or any of the folks present? Dr. Zar, any comments from you having designed our system over the last 2 to 3 years?
That was wonderful, Dr. Sigurwa. I learn from you every time you talk about shock, something new. And I think that probably for me, the biggest take-home message is more important than the device itself is the team and the process. And I think that this is what we experience every day in our practice, because it is a high mortality. AMI with cardiogenic shock, it is high mortality. And I think that we use devices as tools in the toolbox, but the thing that we all must have is the care pathways that you outlined, because there is no single device that is going to get the mortality lower. It is the team approach and the pathways for those patients. And I think that every trial that you presented help us understand this better.
Thank you so much. To me, that was the really insightful part from that one slide that showed system versus no system. And MCS overall utilization was lower in the shock center, but there was greater impact of the system of care in choosing the type of device, as opposed to always believing device A or device B is the answer.
I have invited some in the chat, in the online, the representative from Ministry of Public Health Service Plan to be Center of Excellence. If you are on online, you can ask Professor Sigurwa. I think it is time for public health Minister of Public Health to set up the National Shock Center by doing collaboration and listen to this presentation carefully and then start up, because we need a national shock center, and not every center can be a national shock center. According to this lecture, we have to prepare a lot of resources, including people, including material, including commitment to perform. And today we start first with we speak on the same nomenclature of shock from A to E. And second, we'll do everything with the invasive monitoring, including PA line, and also a lot of things that we have to learn from this lecture. If you have any question from online, please feel free to ask the member representative from Ministry of Public Health if you are there.
ดร.บุญส่งเกษตรมงคลทองบางกอกขอส่วนหาดใหญ่ great presentation, and I have some question. For the first step, are you suggestion about this strategy for the ECMO peripheral or central by CBT surgeon about the strategy, or skip to train the interventional cardiologist to insert the ECMO by the peripheral? Thank you.
And so it's a wonderful question as to how do you initiate ECMO and by what techniques and by whom? And what I'd say is all politics are local. But if in fact you state what are the competencies of cannulation and initiation of ECMO, under what circumstances, and then how do you, as an ECMO team, approach this? To me, that's the most important thing. Whether he implants it in the cath lab or you implant it in the cath lab, to me, what's most important is that there is competency of arterial and venous cannulation, and that there's philosophic agreement and teamwork about it. Because, I mean, I can put cannula anywhere, but I can't always put them anywhere, and vice versa. And so I think it's best when it is jointly agreed upon and administered, and that varies from site to site to site. On our flight to Tokyo, Firas was on the internet and reading emails, and this exact email came from our credentialing committee, was about cannulation and privileges and so forth. And, both of our answers were identical, to the head of credentialing. It's really important about the competencies and the fact that we work side by side with the cardiothoracic surgeons, who are an integral part, just like we're the same. I mean, they're just, there's a surgeon, there's an interventionist, but we are the team caring for this patient. And so that's what we wanted to make certain. And conversely, if there's a member of the ECMO team, but they've not trained and they are not used to cannulating, I could care less if they're an ECMO specialist. They're not putting 16 or 17 French in any vessel, whether they have an ultrasound or not. That's going to be him or both of them. And I don't care if you know that you should use ECMO under this scenario. You're not competent. So that's our approach, at least.
And the same answer for the ECPR too, about the site or the surgery.
About the use on ECPR. So I think, again, when we take a look at the broad application of ECPR, the overall outcomes remain futile, and meaningful survival neurologically is minimal. And so I think the question is, which group of patients witnessed bystander initiated, EMS arriving, intubated, evidence of outstanding CPR, not just the fact that I was doing this, but obviously with the tools that know effective chest compression, tidal CO2, and all those things. So I think in those scenarios, you can selectively administer it. And then the question is how do you rapidly initiate it? Because every minute counts. And so I would say the same thing. How do you organize? And organizing is very different. The time that putting your perfusion team together in the operating room in order to initiate ECMO is inadequate to initiate ECMO for eCPR. OHSU at this moment does not have an eCPR program. We don't have the beds. It remains profoundly futile. And the resources to do so, we would rather focus those resources on other cardiovascular patients that need access to our facility that otherwise would not have it while we are, supporting these patients for, 5, 7, 8, 9 days. And so I think it's a different engineering pathway for rapid ECMO initiation in the emergency room. So I would start by stating, here are the things that need to occur in this time frame, and then you have to design the system in order to implement it. If I'm 40 minutes out and that patient has already been VF to rest for 30 minutes and you're wanting to implement ECMO, it ain't going to happen. So you have to compress those time frames, look at what your infrastructure is, and then say we either can do it or not. If we can, who has to be competent to initiate it? And then the two of you have to believe that person's competent.
Thank you so much.
Thank you. I really appreciate the privilege of presenting to all of you this morning. And I'm so excited that we're here together exchanging knowledge now for the third annual symposium. It would be higher than that third, but COVID interfered. Thank you.